We are going to go ahead and begin. Again, welcome everybody. Thank you so much for taking time out of your busy days to join us. We are very excited to be chatting with you today about our topic, supporting clients with autism and outpatient therapy, practical strategies for clinicians. I'm Donna Phelps. I'm a BCBA, LABA, and I am the Assistant Vice President of ABA Services here at Northeast Family Services. And Mariana, I'll let you introduce yourself.
My name is Mariana Knight. I am the director of our outpatient Real Help. We offer outpatient therapy, and I oversee that program.
All right. So there is a Q&A function as we're going throughout our content today. Please feel free to add questions in the chat. We will answer as many of them while we go, but we'll also save some time for questions at the end. Please genuinely use the chat. We're happy to answer any questions that you have, and we'll get to as many things as we can in the time that we have together. So our learning objectives for today, we are going to start by describing the core characteristics of the autism spectrum disorder diagnosis. We will be discussing the appropriateness of outpatient versus ABA as treatment methodologies. We will talk about some common treatment barriers, how to use those strategies in session, and then we'll wrap up by giving you some resources and then save time for questions at the end. And again, please feel free to use the Q&A function as we go. So a little bit of an overview. We're going to begin with the diagnostic criteria, then go into the appropriateness, talk about the treatment barriers and how to use those strategies in session. So we will jump right in to autism spectrum disorder diagnostic criteria. So there are three basic elements that an individual needs to present with in order to be diagnosed with autism. There needs to be persistent deficits in social communication and social interaction across multiple contexts or environments. There needs to be a restricted and repetitive pattern of behavior, interests, or activities as manifested by at least two different topographies or different types of behaviors. Those symptoms have to be present in the early developmental period, but sometimes they don't become fully manifested until the social demands of the environment exceed the individual's capacity. Or sometimes what we see as individuals might be masking the symptoms with learned strategies as they go. The symptoms have to cause clinically significant impairment in social, occupational, or other important areas of functioning, and those disturbances cannot be better explained by an intellectual disability or a global developmental delay. We're going to go into a couple of these things in detail, but before we jump into that, I want to share a video with you all. I have a brief clip of an interview with Temple Grandin, who is an individual on the autism spectrum who is a very well-renowned researcher, and she's published things in the area of I want to say like farm studies, which is really interesting. So she talks about her experience having autism and going through the diagnostic process. So I just want to take down my share for a moment, switch my screen. Okay. Does the sound work okay?
I can't hear it.
Let's try it now. Any luck?
Yep, it's working.
Still not hearing it, Donna, and they're saying that there's feedback on your end when you're speaking.
Oh, the audio is not working?
No, the audio is not working, and there's feedback on your end, a bad echo.
Donna, let me see if I can share mine.
Sure.
Let me see if that will work. Um, though the share sound function is grayed out. Donna, let me know if you hear it.
Sure.
You never get cured of autism.
I can
What
hear
you
it.
do is you learn better as you learn one more. Speak to us for,
I'm going to start it over.
you never get cured of autism. But what you do is you learn better as you learn. Speak to us for. There's no serious my time. I can remember the frustration.
Oh, when you muted it, shut off the sound.
Is it back on?
Mhm.
Rocking, that's the kind of kid they just put away in the institution. I had a speech teacher that worked really hard with me, and I can't emphasize enough the importance of young children getting early intervention. You got a 2-year-old, 3-year-old, no speech, don't play. High school, absolutely. Teasing, teasing, teasing. I got kicked out of school for throwing a book, teasing me because teasing really made my life miserable. And the only places I could get away from teasing was the specialized activities. Things like horseback riding, electronics riding, when I was strong and sad, I was not glad to become a recluse in my room. I had to get out and do things. I always kind of baffled at just how illogical people are in their thinking. I'm very logical in my thinking. But when I was younger, I didn't know that other people thought more in words. You see, I think in pictures. If I don't have a picture, I don't think. And my mind is very, very associative. Being a visual thinker, I have to tend to put things into categories. You see, autism is a very big spectrum. At one end of the spectrum, you've got half the people in Silicon Valley. Then at the other end of the spectrum, you've got somebody who's very handicapped and makes nonverbal is going to have to live in a supervised living situation. We're not like big spectrum. And Einstein probably labeled autistic today in a lot of school systems because he had no speech until age 3. Interested in seeing something that makes real change. I've done a lot of work that's made a lot of improvements in the livestock industry. I think I've helped a lot of kids succeed. I want to see the kids that are like me succeed. That's the kind of stuff that makes me happy. When I see the things that I do make a difference.
All right. Okay, wait, stop.
Consider to be non-verbal. Multi-nuance with the
You want me to put my screen back up, Mariana, with the slides?
Yep.
Okay. I'm sorry about that if it didn't work correctly for anyone. We're happy to send out the slides afterwards if anybody would like access to it. Okay. And the videos are linked in the slide deck. All right, so getting into a little more detail on those different diagnostic elements, the social communication and social interaction kind of gets lumped into one category, but this really encapsulates all components of social communication and interaction, not just vocal verbal communication. So individuals who have an autism diagnosis have to present with deficits in social emotional reciprocity, meaning there might be abnormal social approach or failure to have that kind of back and forth conversation. As an example, you might, greet an individual on the spectrum, say good morning or ask a question, and they may not reciprocate that question automatically. There could be reduced sharing of interests, emotions, or affect, meaning they could present with just less emotional manifestation, and failure to initiate or respond to social interactions. And we'll talk more specifically about this later on when we get into strategies, because this very much so is something that can be very impactful in outpatient therapy. With respect to the social interaction component, this can also mean deficits in nonverbal communicative behaviors for social interaction. So not just, the failure to manifest emotions on their face, but this could also be, failure to interpret or have the ability to understand nonverbal social cues. This could look like poorly integrated verbal and nonverbal communication. So not necessarily being aware of personal space or being able to interpret some of those less overt communications. There can also be abnormalities in eye contact and body language, or deficits in understanding the use of gestures. And sometimes individuals on the autism spectrum will present with a total lack of facial and nonverbal communication. And that's not to say that we can't, help those individuals acquire those skills, but rather that, it's not something that they're going to be able to inherently interpret. So when we look at these diagnostic elements, the Diagnostic and Statistical Manual categorizes these components of the diagnosis into a level system, where individuals tend to be kind of placed at either a level 1, a level 2, or a level 3, depending on the amount of support that is needed to navigate this particular deficit. So individuals who present as a level 1 with the social communication element might be individuals who they have some difficulty initiating social interactions. They might have some noticeable impairments in communication, maybe some, atypical or unsuccessful responses to social overtures of others, and they may appear to have decreased interest in social interactions. So this is going to be, your lower support needs individuals. And moving on to the middle level, or level 2, these are individuals who require substantial support in navigating these deficits. So these individuals are going to have more pervasive deficits in verbal and nonverbal social communication skills. Social impairments might be apparent even with the supports in place. There could be limited initiation of social interactions and reduced or abnormal responses to social overtures from others. And then on the higher support needs end of this range, we have a level 3, which would be individuals who require very substantial support. So this would be those who present with severe deficits in verbal and nonverbal social communication skills, cause severe impairments in functioning, very limited initiation of social interactions, and minimal response to social overtures from others. So when we're talking about this level system, we usually indicate low support needs would be like a level 1, and a high support needs would be a level 3. The other element to the diagnostic criteria is having restricted, repetitive patterns of behavior, interests, or activities. And the way that this is described is stereotyped or repetitive motor movements, use of objects, or speech. The way that we tend to talk about this is these stereotyped or repetitive motor movements are non-functional. They're not things that are, helpful behaviors. They're not things that have, a lot of functional purpose outside of just checking this, this element here of being a repetitive behavior, interest, or activities. So sometimes we'll see things like simple motor stereotypy, which could take the form of like hand flapping, body rocking, those sorts of repetitive behaviors. I have a picture here on the side. A lot of times individuals on the spectrum will line up toys or objects, or they'll kind of flip or tap objects. They may engage in echolalia, which is non-functional repetition of what others have said, or things that they've heard perhaps in movies or YouTube videos or TV shows. But the key to the echolalia is that it's not used contextually. The individual might be repeating a line from a particular TV show, but that doesn't have anything to do with the environment and their current circumstances, or repetition of idiosyncratic phrases or perhaps sounds. So, along this line, not just having those restricted or repetitive patterns of behavior, but there can also be an element of insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior. And this oftentimes is the where some of the challenging behavior can stem from because of this, very perseverative insistence on sameness and that inflexibility that can lead to, dysregulation, agitation, and, a variety of different topographies of challenging behavior. So, what this can look like is individuals could become very distressed at small changes, having a difficult time navigating transitions, very rigid thinking patterns, needing things to be a particular way or follow a particular process, or needing to take a same route or eat a same food every day. And then finally, we have the restricted interests. This can be, a restricted fixated interest that is very, very high in intensity or focus. It can also look like strong attachment to or preoccupation with particular objects, or, excessively circumscribed or perseverative interests. And I have some images here of a canister vacuum, a yellow school bus, and a fire extinguisher because I worked with an individual once who these were some of his very favorite items. These are, pretty common everyday things, but these were like his very, very favorite things. And again, we'll talk about ways that we can incorporate these preferred items and activities appropriately into treatment. But his very perseverative and attachment to these particular items met that diagnostic element of the very restricted interests in items that most people are not going to share. I do have another video linked here because of the difficulty we had with the last one. I'm not going to show this, but if anyone's interested in having access to these slides afterwards, please email Gary or Maria. They'd be happy to help you and pass along the slide deck, and then you'll be able to watch this. I'll just give a little bit of an overview. So this is it's meant to be a simulation of the sensory experience of someone on the spectrum navigating a school hallway. So it really aims to highlight some of the things that are more salient to individuals with sensory differences and how that can be very impactful for individuals as they're trying to navigate the environment around them. So again, individuals on the autism spectrum can have either hyper or hypoactivity to sensory input or unusual interest in sensory aspects of the environment. They can also present with apparent indifference to pain or temperature, an adverse response to specific sounds or textures, excessive smelling or touching of objects that might be preferred, or a visual fascination with lights or movement. And again, these are all different ways that that sensory component can manifest. So just like the deficits in the social and communication element, we also use a severity level to categorize the degree to which an individual is impacted by these restricted and repetitive patterns of behavior. So the same system is in place here. Level 1 would be your lower support needs individuals, and this could be a general inflexibility of behavior. It can cause significant interference with functioning in one or more contexts, difficulty switching between activities, problems, or organizing and planning can hamper independence. Then moving on to level 2, these are individuals who require substantial support. And here we're going to see more inflexibility of behavior, difficulty coping with change, or other restricted and repetitive patterns of behavior appear frequently enough to be obvious to the casual observer and can interfere with functioning in a variety of contexts. Additionally, we will likely see distress and/or difficulty changing focus or attention. And then finally, we have our level 3, where individuals require very substantial support. These are our high support needs individuals, and we're going to see inflexibility of behavior, extreme difficulty coping with change, or other restricted and repetitive behaviors that markedly interfere with functioning in all spheres, great distress, or difficulty changing focus or action. And with that, I will turn it over.
Thank you. So we will talk about some different treatment options. So I know, like I said, I oversee the outpatient therapy division or a piece of it anyway. And we have several clinicians who often are working with clients that are struggling with some mental health needs in addition to also being a person on the spectrum. So we're going to talk about some different treatment options that you can use to and implement in session to help support your clients better. Okay, so something to consider as you're providing services as an outpatient provider is determining and being aware of the different type of treatment options and what might be a potential referral for other options. So something we'll want to consider. So ABA is designed to support kiddos who are on the spectrum and is a really awesome resource for kiddos that are nonverbal or low verbal. If they have any sort of behavior challenges that you're noticing, maybe sustained tantrums, severe self-injury, harm to others, running away, those should be some indicators for you that are kind of going off in the back of your head that say, wait, hold on, I might want to staff this with a supervisor. We might want to be considering an ABA referral. Or any kiddo that is on the spectrum as a level 3 that Donna just talked about. So have these stored in the back of your head so that as these things come up, you can make sure that you're staffing them with your supervisor. For outpatient, you might find that your client has some flat affect, which we might expect to see, is avoiding eye contact, is having some difficulty with emotional regulation, but is able to redirect when you're prompting. Level 1 and potentially level 2. So we want to keep these things in mind about appropriateness as we are determining what the best course of action would be for our client. So next we're going to go into some common treatment barriers. So we'll talk a little bit about some items that clinicians might run into or some barriers that clinicians might run into when they are trying to present, when they're working with their clients in the therapeutic space. So something that clinicians might notice when working with a kiddo on the spectrum is they might notice that there is some limited emotional and communication reciprocity. So they might notice that as they are trying to engage in conversation, that they're not getting, I like to call it the back and forth, right? Like they're not feeling that they're getting answers in a way that would promote a lengthy conversation. Rigidity or resistance to change. Sensory sensitivity. So you might notice that your client is body rocking, hand wringing, flapping, hand pressing. That's okay if those things are occurring. So what we really want to be focused on as their outpatient clinician is that we're creating a space for sensitivity needs. So if you notice that a client is rocking back and forth or flapping their hands, it's okay to ask, are you okay? And then we might want to follow up with, do you need to get a fidget? Or do you want to go get some water? Or maybe do you want to take a lap around the room, right? Like, do you want to stand up and then maybe walk a lap around your room, come sit back down, and we can finish where we were. I know there are different modalities for outpatient. So some of you are providing outpatient services in an in-person setting. Some of you are providing outpatient services virtually. So I know virtual clinicians typically need to be a little bit more creative in the implementation of different interventions. But asking for a fidget, allowing them an opportunity to grab some water, giving them the opportunity to take a wiggle break is okay. And sometimes clients, they might appear disengaged, but we do want to be mindful that just because they're appearing disengaged doesn't necessarily mean that they are disengaged. So now we're going to go over some strategies that you all can use in session. We tried our best to make these strategies that are usable, something that you can jump right in and use so you have some resources to take with you at the end. So one strategy that is recommended is the incorporation of your client's interests, right? So an example of that might be an emoji chart that, let's say the client's hyper-focused on Pokemon, right? Making an emoji chart that represents their interests and also incorporates your therapeutic intervention. So for example, for the Pokemon example, I have that maybe your angry emoji could be Charizard, your happy emoji could be Jigglypuff, and I'm sorry that I'm such a Pokemon nerd, but I could talk about them for days. So And honestly, the use of AI makes this really, really easy. So Donna and I, when we were putting this together, we were kind of messing around on ChatGPT to see what we could have it make. And we put in, make an emoji chart that represents emotions and incorporates Pokemon. And it put together something really cute, super easy for your client to understand. So if your client is interested, for example, like Donna was showing, she was just mentioning she has a client that was super interested in vacuum cleaners and school buses, and I think it was a fire extinguisher. You can potentially, Donna, was all of that the same client? Was that all one person's interest?
It sure was.
Okay, so you can find a way to incorporate those interests onto an emoji chart. Maybe make happy be the magic school bus because that bus is smiling. And then, maybe make angry the fire extinguisher, putting out a fire. So there are ways you can kind of be creative to incorporate what your client is really, really interested in and also keep it therapeutic at the same time. We want to make sure that we're showing interest in appropriate topics to help us supporting with rapport, right? That's the same thing I think that we would do with all of our clients. So we want to make sure that we're extending that same courtesy to any kiddo that's on the spectrum and keeping in mind that the interest might be a fire extinguisher, it might be a school bus, it might be a vacuum cleaner. And that's where we would really show some interest and really allow them the opportunity to share with us. Talk to me a little bit about what makes this vacuum cleaner your favorite? What do you like about it? What do you not like about it? What do you think about the sound it makes? We really want to talk to them about their interests to help them feel a little bit more comfortable in session. And then it also gives us the opportunity to model and prompt appropriate communication skills for them as well. So some other strategies are incorporating some forced choices, right? So what that might look like for your client would be the same that we would want to provide the client with a set of options, maybe two, so that we're not overwhelming them a ton, but two options that might help them feel empowered and have some awareness of what's going on in the session. So for example, if you're noticing that your client might need a break, it would be appropriate to ask, so would you rather listen to a song or would you rather have a wiggle dance, a dance break? We'll offer two available items and activities rather than asking open-ended questions. I know when we're in graduate school and we're learning how to do therapy, they are beating it over our head that we should be asking open-ended questions all the time, always use open-ended questions. But we want to be mindful that sometimes for certain populations, open-ended questions can feel very overwhelming and can sometimes put clients in a space of confusion or in a space of, the word that's coming to me is blankness, where they're just kind of not sure how to answer or feeling just kind of stuck in how to move forward with your answer. So in those instances, offering forced choices works out really well. So we want to make sure that we're setting expectations with clear, concrete language. So maybe we want to avoid using maybe, right? So instead of saying, maybe after we're done with this, we might try this, versus first, we're going to talk about X, then we're going to move on to Y. So we want to use as concrete and clear of language as possible. We want to use first, then language to make sure that we're promoting understanding of temporal relationships and expectations. Then we encourage providing written reminders or visual cues for expectations. So if you notice in this picture of Donna and I, we used the timer that is located within Zoom to provide your client with a very clear and concrete understanding of when we're going to be ending one task and moving to the next. So maybe, for example, we might say, we're going to work on emotion identification using this emoji chart. And then after we do that for 10 minutes, we're going to take a break. Zoom has the functionality in the apps section. They have a free timer that is something that you can toggle on and off if you want your client to have the accessibility to visually see it. So as you see in this picture with Donna and I, we toggled the timer on so that the client would have the opportunity to see, okay, we're counting down, and they can visually see and have a visual cue for when we're expecting to transition from one activity to the next. This will also help. We also recommend providing advanced warning to changes in the routine or to signal the end of an activity. Again, the department that I oversee is outpatient for virtual therapy. So we have the Zoom timer incorporated into the session, but you can also, if you're seeing clients in person, a physical timer, I think even a clock. When the minute hand gets to the 5, we're moving on to the next thing.
And if I could just add to this one a little bit, all of this kind of connects back to those restricted and repetitive interests that we talked about within the diagnostic criteria. By giving the forced choices, by setting the expectations with clear language, by giving the, very specific time that's going to be allocated to each of these things, we're eliminating the variability and what is the unknown for the individual, which is going to help them feel not only more comfortable, but also more successful because they know exactly what the expectation is, they know what you're looking for from them, and they know what's coming. And I think that really creates an important element in the therapeutic environment when you have someone who is, comfortable because they know what's expected of them, they know what's coming, within the session.
Thank you. So, and we have a question that's asking, what do you suggest to do for clients that do not understand time? So, for kiddos who don't understand time, I would recommend if you could potentially navigate and so I would likely still say, okay, in 10 minutes we're going to transition. In 5 minutes I'll give you a warning. So I would probably have it up, and then at the 5-minute mark I would say, hey, all right, we're at 5 minutes, so we're going to do that time again, and then we're going to move on to the next thing. And then I would be more verbal in my expectation of when we're going to move. I would verbally explain, okay, we have 5 minutes, now we have 3 minutes, now we have 1 minute, and then we're going to move on. When this gets to 0, we're going to move on. Donna, I don't know if you have a different idea or thought.
Yeah, I was going to say, so they also make some really cool visual timers. You can find things on YouTube if you are physically, present in person with one of your patients. I think they're called a time timer. You can get them like on Amazon, and it literally is a wedge of, color, and then it decreases as the timer counts down. So it creates a really nice visual for individuals who don't necessarily have the concept of the passage of time, because they can still visually see the size of that wedge getting smaller as they get toward whatever the end of the timer is. But like I said, you can also find things on YouTube. They make like, it's like an hourglass. And as you watch the amount of sand fall through, it means the time is, progressing and you're headed toward the end of whatever the amount of time is that you've given. So visual timers are another really great tool.
I like the idea of an hourglass, and then maybe like sharing your screen to show the timer. Okay, so another strategy is working to help your client with navigating or creating some predictable routines, right? So that, again, with therapy, you can start that off even with a like therapy table of contents that you even can pull up and screen share that shows, okay, so from this time to this time, we are going to do a check-in about your day. From this time to this time, we're going to play a game. From this time to this time, we're going to have a break, and trying to keep that routine as predictable and as frequent as possible, right? If you know you're going to always start off each session with a check-in that's more like a game style, start every session with that. End every session the same way. Try to keep the routine and the flow of your therapy session as predictable as possible. We want to provide a structured environment with familiar routines and clear expectations. So again, being as clear as possible, we're going to work on X. What I need for you to do is Y. Schedules, visual or text, depending on age and developmental level, can help provide structure and comfort. Again, so this picture shows somebody that has a schedule for their day-to-day activities, but you can also create one that's very similar for therapy, or that's appropriate for therapy. Use of visual supports, screen share with a written list of activities to help set clear expectations and keep session momentum. So I know I was saying you can share your screen with a therapy table of contents, which sounds really fancy, but it doesn't have to be. It can be if you're working with a really small little like a table of content. We're just getting way too advanced here. You can put pictures, right? So you can have a picture of whatever you want to represent. Second, have a picture of whatever you want to represent. And then advanced notice of transitions. So we do recommend that before you move from one item on your itinerary to the next, making sure that we're giving them a notice and saying, hey, we're going to move in 5 minutes. We're going to move from X to Y. Okay. So something that's really important when we're working with kiddos on the spectrum is making sure that we're addressing their sensory needs. Creating a space where the child feels comfortable and engaging in self-soothing behaviors is really critical and important for their care. So if you're noticing that your client might be stimming, we want to it's okay. Like we want to allow the safe space and the ability for them if they need to, if they feel the need that if they're rocking or, you're noticing that there's excessive movement, it's okay. And we can also, like I was saying before, continue to offer, are you okay? Do you want to take a break? Do you want to take a lap? And getting back into therapy.
And if I could just add to this one as well,
Sure.
again, thinking about the sensory elements here, everybody engages in behavior that is sensory driven. We all have, flavors that we like, we have scents that we like, we have textures and, fabrics and things. And then similarly, we have things that we don't like. So this is very much so not specific to individuals on the spectrum, but this is something that everyone experiences. And I think, normalizing this and understanding that this is a way that the individual you're working with is processing and not necessarily something that needs to be stopped is an important thing to keep in mind, because our individuals who have an autism diagnosis do have these unique needs. And definitely, if you have the opportunity, go back and check out that second video, because I think it does a really nice job of highlighting how different those sensory elements can really be for the individuals that we work with. But I think the important piece here is creating that space where the individual feels comfortable engaging in those self-soothing behaviors. That's where the normalization of this comes into play, because everybody engages in these behaviors. It's just a matter of, the topography of my, stimming might look different than that of someone on the spectrum. So creating a space where they're able to engage in those behaviors is really important.
Okay. So how to work through resistance. I feel that as a supervisor, that is the number one question that I get for clinicians that are working with a kiddo who's on the spectrum. A lot of times they'll come to supervision and say, they're not engaging, I'm asking questions, they're not really responsive, or they're responding with just a one-word answer, so I'm not really sure where to go from here. We want to keep all of those things in mind that, again, what we were saying earlier, because it appears that they're disinterested, it doesn't necessarily mean that they are disinterested. So it's something that we want to really keep in mind. So some ways we can work through that are reducing demands, right? We want to be mindful that we're not coming into session asking for the client to complete a lot of different tasks. Something that we recommend is making sure that we're asking questions about their preferred topic, right? So whether that be about the fire extinguisher, about the bus, about the vacuum cleaner, that we're asking questions about their preferred topic, and that we are incorporating those interests into their treatment. Something that I recommend doing is that when you're talking to let's say you're running into a situation where you're really finding that you're experiencing some resistance and you feel like the client's shutting down and you're really struggling to get more information or to get an answer to what you're working on. What I would recommend is prompt your client by asking questions about something that they're interested in. Once they're starting to talk to you about the thing that they're interested in, and you find that, okay, we're in a good flow now, right? Like we're moving, like I'm asking questions about their interest, they're responding to me about their interest. This is going really well. Then start to slide in some more challenging clinical questions, right? um, and use the momentum, using the momentum of the conversation from their interest will likely transition into increase in momentum in the conversation overall. And you'll have a higher likelihood of getting the response to your question. If you
I can
start
just,
noticing also, oh yeah, go ahead.
no, go ahead, go ahead. Sorry.
I was just going to say, so if you're noticing that you're asking a more, you're starting to ask some clinical questions and they're speaking, and then now they're kind of starting to, not answer as many questions, I would switch right back to what they're interested in, have that conversation some more. Once we're back on the same pace of having them responsive, then I might slide in another tricky clinical question, and keep kind of that ebb and flow of the conversation to keep it going. Go ahead,
And
Donna.
that's exactly what I was going to say. These aren't things that can be used or that have to be used in a vacuum. You can incorporate a forced choice with reducing demands, or you can, if you have two tricky clinical questions or, topics that you need to address in a session, you can give forced choices within this momentum paradigm. And you can start with the conversation about the preferred items and activities, move into the more challenging clinical things, and you can say, okay, we have to talk about this thing that happened to you at school, or we have to talk about this thing that happened over the weekend. Which one do you want to start with? So you can still incorporate some of those other strategies that we talked about within these recommendations as well for those, when you do get stuck working through the resistance.
Okay,
Okay.
so who has questions? The fun part.
And please feel free if you have specific, client situations or things that you're encountering, you're welcome to ask questions so long as they don't have any identifying information. We're happy to make recommendations.
And just
Yeah,
type
and
your
take a moment.
questions into the Q&A.
Take a moment, think about your caseload, think about the clients that you're working with that might potentially be challenging for you, and feel free to ask any questions.
And think about what brought you here today. We don't have any specific questions. I'm happy. Oh, no, it looks like we do have some things coming in. Great.
And if we don't have too many, Donna, I can attempt the video.
Okay. Yeah. I was going to say, I can also, share some examples of what some of this looks like in practice. But we've got a great question. When working with a family unit, what are some useful strategies to help correct behaviors? This is an awesome question. And I think one that is definitely impactful, knowing the profile that we're talking about here today. I think the biggest thing to keep in mind when you're redirecting behavior is that, just like, energy, it needs to be channeled somewhere. So if you're asking an individual to stop engaging in some kind of behavior, you have to give them some sort of alternative to do instead. And when we were talking about, the sensory opportunities and, using fidgets and having movement breaks, if you're asking an individual to stop body rocking, or you're asking them to stop, chewing on something inappropriately, we want to make sure that you're giving them a safe and functional equivalent, something else that they can do with their energy, with their body instead. And I think if that's kind of an approach that you can take, not only will it help redirect that behavior to something that's going to be more pro-social and appropriate, but you're also, teaching a strategy that's kind of embedded within your session. Marianne, I don't know if you have anything else that you want to add to that.
No, I think that's right on the. I think that's right on the money.
Okay, and then we have another question. We have someone with ODD who only wants to color pictures. How do we change the routine? Slowly. It's the answer to that. I think if you have someone who is very, very, perseverative, only wants to color pictures, I think it's important to honor that and allow them to, color pictures, but do so with some sort of time restriction or limit, and then use some of that first then language. So first, we always color pictures when we start our session. We can definitely do that, but then we're going to move on to this other activity, and maybe pairing that with a visual timer of how much time they can spend coloring pictures would be an appropriate support. I might also suggest, again, just slowly working on that across time, where, if the individual expects to color, for 45 minutes of session, and that, they talk while they do it, and you want to gradually decrease that, maybe the first expectation is 40 minutes, then it's 35, then it's 30. So as you go across time, you're reducing the amount of time spent coloring pictures. Marianne, I don't know if you have anything else you want to add to that
Yeah.
one.
Yeah. So I agree with, right. We don't want to just come in and just shut the coloring down, especially if we're working with a kiddo that does have ODD. If we come in and try to shut things down, that's usually going to escalate the opposition. So the shift is more about using the coloring as your entry point and then shaping flexibility over time, right? So I would say, you want to start where the client is. If coloring is what they'll engage in, use it. Use it to build rapport and reduce power struggles. Trying to immediately challenge the routine, I think, will just enforce the oppositional behavior. So instead of we're not coloring today, we might want to try what Donna was, we can color for 10 minutes, then we'll try one other activity. You can choose between A or B. I think keeping some of their autonomy intact will really help support. I think that's the key when we're working with kiddos that have ODD. And then we can use coloring as a bridge, not the whole session. So we'll do some integrative interventions into the coloring, right? So like as you're coloring, talking about emotions through colors, like, oh, I like that you picked that yellow. Let's talk about what do you like about yellow? You can maybe even create like a coping skills poster. They can draw situations and maybe problem solve together. There might be some ways we can continue the coloring in a clinical way, and then start gradually introducing 5 to 10 minutes of a new activity and then start increasing that slowly over time. So I know we were talking a little bit about having the structure and having, what I was referring to as the table of contents, where you can have first color, then activity, then back to coloring if time maybe. I think having some of that predictability will reduce some of the resistance. And then I would also say that we're making sure that we are reinforcing flexibility as much as possible, and we're giving as much praise as we can when we notice that they're able to tolerate change, right? So say like, I noticed you didn't want to switch, but you tried. And for me, that's a big deal, right? It's a big deal for me that you tried to do something that you didn't necessarily want to do, but you did it. So that is what I have to add.
We have another question. What is the best way to challenge our own rigidity to get things done while understanding the specific concerns and abilities of our clients on the spectrum? I think this is definitely a challenging question for sure. I can kind of share from my perspective as a behavior analyst, and then Mariana, if you want to add things in, I think that there's a balance that you strike once you get to know your client and knowing kind of what their capacity is during session, how many, questions you can ask, what their tolerance is, and how they how they engage with you, how they respond. And I think we have to be flexible and adaptable in our approach to make sure that we are honoring, the space that our clients come to us each day. But also, recognizing that this is a therapeutic service, and we do have, a certain number of things that we have to make sure that we address in the time allotted. So I think, I know I didn't really necessarily give a concrete answer to that, but I think, going into your sessions with the idea of being, adaptable and flexible, but also basing that on your previous experience with your clients. And I think, we always talk about establishing a baseline and understanding kind of what your client's current abilities and performance level look like at the outset of treatment. I think if you use that as your foundation to figure out how much you can push them in a session, I think leaning on that will help you be able to modulate those in-session decisions.
Yeah, I think that that's a good answer. And I think that also something we want to really be mindful of is the key shift is moving from did we complete a task, right? I know some of us go into session, we have our treatment plan written, and we're like, today I'm going to go in and I'm going to teach this kiddo about the cognitive triangle. And that's what's happening in session today, right? The shift is going to be from moving from did we complete a task to did we move the client forward in a way that works for their brain, right? So challenging internal rigidity can be hard. So I think what we'll want to focus on is redefining what practice actually looks like, right? So for clients on the spectrum, progress might look like increased tolerance for change, reduced distress in session. It might be just a small step towards flexibility. Like I would say if a client engages for 2 minutes in something new, I would say that that's meaningful progress. So maybe changing your thought on what progress is for your client could be helpful. And separate the goal from the method of accomplishing it, right? So ask yourself, what's the goal here? Is it emotional regulation? Is it flexibility? Is it communication? Is there another way to get there that fits the client better? I think if you're too rigid on the method or if you're too rigid going into it, you'll miss opportunities to meet the client where they are in a way that's accessible. I know we also talked about using the client's preference as an intervention. So instead of viewing their preferred activity, like the coloring, for example, as a barrier, you can use it as a regulation tool or an entry point for skill building. I think something else that would be helpful is to build in flexibility for yourself also, right? So ahead of time, I know Donna mentioned like we need to also be flexible. Go into sessions with plan A, plan B, and plan C, right? So I have plan A, this is my ideal structure, this is what I would like to see happen. I have plan B, this is if we need to modify engagement. Then we have plan C, this is just completely regulation focused, and this will help to pivot your intervention without necessarily feeling like you failed at what you tried to accomplish in the session. So I would work on some shift in your thought process to be a little bit more flexible, learning how to better tolerate your own discomfort, right? Because I think part of this is recognizing that it can feel uncomfortable to not, complete a task. But that doesn't mean that your session wasn't effective. So sometimes leaning into the discomfort is part of just becoming a more flexible clinician. And I think that that's something that's a skill. That's something that will all learn throughout our clinical careers. And a focus a bit on instead of going into it with the client isn't going to do this or the client can't do this, taking a step back and thinking at it from the standpoint of, okay, what skill is missing that's making this hard right now? And then trying to incorporate a intervention to fill that gap.
Great answer. And I think we have one more question with our last couple of minutes. If a client with ODD constantly fibs, I have to come at this from the angle of I'm assuming there might be a comorbid autism diagnosis. And I'm wondering, are they aware that they're fibbing? Is their perception aligned with other reports that we're getting? Because sometimes individuals on the spectrum will perceive things in a different way, and while it may not, what they're reporting may not align with what a caregiver has reported to you, that may be their reality. It might be how they actually perceived that particular interaction, or they have a difficult time reflecting on their own behavior. And in a situation like that, that might be, I mean, I'll certainly let Mariana talk more about the approach piece, but I might, encourage them to reflect on their perception of that interaction to see, how it aligns. And then you can kind of highlight what the differences might be so that they can reflect on how their behavior is impacting others, because that oftentimes is something that we have to work on with our kiddos on the spectrum. They don't realize the impact that their behavior has on others or how others perceive them. So it might not necessarily be fibbing with the intention to fib, but rather a misperception of that dynamic and interaction.
Thank you. And I think I'm looking at this from the approach of the kiddo is aware. So let's look at this from a different angle. We have 2 minutes left, so I'm going to say this quickly. With kiddos with ODD, fibbing is usually less about deception and more about avoiding a consequence or trying to stay in control or testing limits. So if you go into it as lying is bad, it usually turns into a power struggle. We want to have the approach try to be more about shaping honesty and reducing the payoff of dishonesty. So really the overall bottom line, I would say, is the goal isn't to necessarily try to like catch them in a lie as much as it is to try to make honesty feel safe, making honesty feel easy, making honesty feel more beneficial than telling the fib. If we're doing those things, we're slowly removing the payoff of them telling the fib. So I would, don't get pulled into proving the truth. Don't allow the space that you're in safe for them to tell you the truth, because that can be a really brave and hard thing for kiddos. And then reinforce the honesty immediately. As soon as it happens, like, I appreciate you being honest about that. That really helps me trust you. And again, I'm talking about for kiddos who are aware that they're fibbing.
Okay, and I know we are just about at time. Again, we're happy to share the slide deck with anybody who is interested, but we've got just a couple of different resources here, things that talk about the diagnostic criteria that we discussed, some best practice guidelines, and then how to make that determination if ABA is the right fit for one of your clients, and then a couple of places where you can find just a collection of other resources. We do have our email addresses here. Thank you all so much for joining us today. We really appreciate your time and attention. If you have any follow-up questions, or like I said, if you'd like the slides, please don't hesitate to reach out. We'd be more than happy to provide it.
Thank you so much for your time.
Thanks, everybody.